profesor de la Universidad de Porto, es cirujano cardíaco en el Hospital de Sant Joan. Muchos lo conocéis, él ya ha estado aquí y además dirige un grupo de investigación extraordinariamente potente con el que nosotros también hemos trabajado y desarrollado proyectos en el área de investigación básica, pero sin duda es un cirujano cardíaco de excelencia, un hospital que tiene un extraordinario volumen, más de 1000 cirugías cardíacas por año, y él lidera un programa dentro de la cirugía cardíaca que es un programa sin duda de élite en la cirugía, que es la reparación aórtica, un volumen importante de válvulas aórticas reparadas en determinados escenarios, y por tanto yo creo que es un área de un gran interés para clínicos, para imagen, para un poco cirujanos, por supuesto, y anestesistas, y es una fortuna que hoy alguien del prestigio de Adelino esté aquí con nosotros. Por tanto, Adelino, muito obrigado pela aceite. En inglés.
En inglés, ok.
Sí, perfecto.
Okay. Además, muchas gracias por la presentación. Es un placer para mí estar aquí de nuevo. Tengo gran estima y amistad por todos ustedes, en particular por José Ramón Juanatey. Estoy encantado de aceptar este honoroso convite. Maybe now I turn to English to speak about aortic valve repair. As you know, the traditional treatment of valve regurgitation has been aortic valve replacement, and it is so in most centers. And even when the valve is still working normally, such in the case of intervention in the aortic root, the typical treatment is a replacement of the valve, so of a normally working valve by a composite graft, including a tube and a prosthesis. As we all know, there was a surgeon that used to say that when you replace a valve, you change the disease of the valve by the disease of the prosthesis. And indeed, both mechanical and biological prostheses have been found to carry a risk of valve-related complications of course, these numbers include minor and major complications, but still is impressive of 4 to 5% per year, which means that a patient at 10 years had 50% of change of having a problem if he carries a prosthesis, which is dramatic mainly for young patients, which are the most population of patients with aortic valve insufficiency. And these complications include thromboembolism, valve thrombosis, hemorrhage related with anticoagulation, prosthetic and endocarditis, which is also at increased risk in a repaired valve, but as you know, the risk of an endocarditis is much higher in a prosthesis, and even the odds of having a successful medical treatment, it's much lower with a prosthesis. And of course, prosthetic degeneration and dysfunction. So what do we need to repair an aortic valve? Is the same as in any other valve. We have to, first of all, understand the mechanisms of the dysfunction, and that's what we have to target in the surgery. And then when we repair the valve in the OR, we have to have some clues whether that repair will last for a long time, or if it has the chance or higher chance of aortic insufficient recurrence in the short term. And I think that for aortic valve repair, and this is what I learned from Al Khoury and also Tyron David, which are pioneers in this sort of intervention, is that like for the mitral valve, you have first to analyze the valve and to identify the mechanisms Then we have always to look for multiple dysfunctions, and for those involved in mitral valve repair, you know that often you repair the main mechanism, but still there are secondary mechanisms that are responsible for residual and sometimes residual relevant insufficiency. And then, like for the mitral valve, we should stabilize our repair with an anoplasty. And the mechanisms of aortic insufficiency for the aortic valve, in a way, have also been derived from the traditional classification of Carpentier for the mitral valve. So you have the type 1, where where in a way there is normal motion of the the leaflets, but then you have insufficiency by annular dilatation or leaflet perforation, and this is the easiest valves to repair. The type 2, where you have excessive movement, chordal rupture or elongation, or papillary muscle rupture or elongation. And then the type 3, where you have restriction of the leaflets, and these are in a way those that are often harder to repair, and those that even when successfully repair are associated with more poor results at the long term. And the same, and this is what Gebrin El-Khoury derived for the aortic valve, you have the same. So you have type 1 functional annular aortic dilatation. The problem in the aortic valve, as I will show you, is that the annulus is not a single plane annulus, and this makes repair a bit more complex. The type 2, you have the cuspal prolapse, and the type 3 is when you have restriction. And as I will show you, this the repair of the type 3 in the aortic valve is also associated with more poor results, and in a way I would, except for very selected cases, I would not advise to repair these valves with type 3. Of course, if it is a young patient, a young woman that otherwise would receive a bioprosthesis, which would also last for short term, of course, this is a very good alternative, but we will know, we have to accept that this repair will fail earlier. And this is a schematic representation of this classification. An important clue for type 1 is that normally you have a central jet. For type 2, you have an eccentric jet, and this eccentric jet and its direction, it's an important source of information to understand which cusp is prolapsing. And then in the type 3, you have restriction, and you can have either central jets or eccentric jets, depending on whether you have only one cusp restriction or more than one cusp. But as I said, often you have a normal valve, but the valve is leaking due to aortic dilatation. And we have to keep in mind the various phenotypes of ascending aorta. You might have a aortic insufficiency in a normal aorta. You can have aortic root dilatation or ascending aortic dilatation. Of course, normally when you have aortic root dilatation is the case when I said that most surgeons often replace these valves even if they are anatomically normal. And this table summarizes what I just said, and in a way also includes here, in a way, how we should address these valves. For the type 1, and this is called type 1A, where you have insufficiency due to ascending aortic dilatation, must very often with just by just replacing the ascending aorta, you in a way reposition the aortic valve in the correct position, and this often is enough to correct the valve. Also, I would advise, and most of the cases we see, because this has been dilated for some times, when you replace the aorta in the normal place, you have some sort of prolapse of the three leaflets, and so I would advise to complement this with maybe some subcommissural annuloplasty or a small plication of the cusps. If you have a dilatation in this 1B of the entire root and ascending aorta, this should be addressed by reimplantation or remodeling with subcommissural annuloplasty, but most of the studies show that reimplantation technique, so the so-called type David surgery, the type 1 David surgery is the one that I would advise. If you have only dilatation of this ventricular aortic junction, often you can do this repair with an annuloplasty of this junction. If you have a cusp perforation, you should repair the perforation with a bit of pericardium, either autologous or bovine. For the type 2, you have to address the cusp, and there are all these techniques, either plication, triangular resection, free margin resuspension, or patch. The use of patch is associated with more poor results, and I would say from my experience that you can resolve most of these problems with plication, and with small tricks it's very easy to perform. And then the type 3, where you have to do shaving, decalcification, patch, and even when you successfully shave and decalcify one of these leaflets, these tend to recur with time. And as I said, it's very important to speak the same language and to know that, to have these anatomic landmarks in mind, and to take correct and reproducible measures of this when you do a repair. So you have to know that the sinotubular junction, we refer to this anatomical site. Then to know that when we speak in commissures, aortic cusps, valsalva sinus, aorticoventricular junction, and that aortic annulus is this functional annulus that involves all of these. Also, during surgery, you have to know that, mainly for speaking with the echocardiographyst, we have to know not only the ventricular aortic junction and sinotubular junction, have to know that when we speak in effective 8, we speak on this distance between the annulus and the tip of the leaflets. Coaptation 8 is the height of really coaptation of the leaflets, and finally geometric 8 that you can also measure with a ruler intraoperatively. And this is quite important for this decision algorithm, because if you have, for instance, a geometric 8 that is this length here, less than 16 millimeters, this is an important retraction, and so you should not pursue with repair, and you should do a replacement. Then in the sinus, if the sinus are larger, you should preserve the valve, but you have to do root replacement. If you have a ventricular aortic junction more than 28, they put 25, 28, I'd say my trigger is 25. I normally do any sort of, I put a ring or do a some sort of annuloplasty if I have an ventricular aortic junction larger than 25 millimeters, and this the commissure angle, which is this angle, and this angle is particularly important for having a clue if there is one cusp that is in a way smaller than the others, but this is not most often the case. This angle is particularly important when you repair bicuspid valves, because if you have an angle that is less than 160 degrees in a bicuspid valve, you have to reposition this for closer to 180 degrees. And if this angle is, for instance, closer to 120, then you should not pursue with the valve repair. How do you also address aorta for repair of the aortic insufficiency? If you have an aortic annulus less than 25 millimeters, you can skip the annuloplasty or just do a small Cabral stitches called subcommissural annuloplasty. If you have more than 25, you should stabilize both the ventricular aortic junction and the sinotabular junction. If you have a dilated root, you have to do either remodeling or reimplantation. But if you have an annulus more than 25, you should use the reimplantation or the remodeling plus a ring in the base. If you have an ascending aorta, you just can put a tube in the ascending aorta. But if you have a dilated annulus, you have always to do an annuloplasty. And then once you identify the mechanisms, and through the mechanisms you decided your surgical strategy and you perform the repair, what are in a way the predictors of a successful repair? As I said, if you repair a type 3 aortic insufficiency, this is from one study, but most studies show that the results are less reliable and less reproducible, and the valve deteriorates on the short term. You see it also here. You see that addressing the cusps have not a major impact in the repair. If you have a dilated annulus and you do not address the annulus, the repair will also fail. So it's why I insisted that, and most of these in a way algorithms always require an annuloplasty when you have a dilated ventricular aortic junction. And that's what you see here. If you use a reimplantation even with a dilated annulus, the results are very good. You see here that this is the same on the left, but on the right you can see that the use of leaflet repair. So if you have to do a David in a Marfan patient that has a prolapse, if you correctly address this prolapse, you see that the results are similar. So the use of plication and leaflet repair has, if correctly done, has no negative impact in the outcome. The use of pericardium is associated with worst results on the long term. And then this is something that you should know also beforehand, and that is associated with poor results. But then when you are analyzing your result, you have to keep all this in mind. You have to see if the annulus, the sinus, the sinotubular junction, the tubular aorta have been replaced to the correct measures. But then you have to measure coaptation length, to look at the position of the tips of the annulus. This should be above the ventricular aortic junction. You should avoid large bellies of the valve below the ventricular aortic, below the aortic ventricular aortic junction. Also, you should know that the presence of a mild central jet is considered a perfect result, because the simple fact that you slightly plicate the leaflets leaves small anatomical, so it's the central coaptation will never be 100%, but if this results in a mild central jet, this has no negative impact in the long-term outcome, and of course measure the other indicators of aortic insufficiency. And you can see that if you have coaptation above the annulus and no residual OR, results are excellent. If you have some residual OR, but coaptation above the annulus and coaptation length above 4 millimeters, the results are similar. So this mild central ER has no negative impact on your outcome of your repair. But then if you have coaptation above the annulus, but coaptation length is less than 4 millimeters, you know that this will start to fail. And if you have coaptation below the annulus, then the result will be quite poor. I have here a couple of examples of different types of aortic valves that we have repaired. This is a 51-year patient that had a tricuspid valve with prolapse. You see this cusp, you see these jets directed to the anterior mitral leaflet, and normally you can see if you had in the normally you can see a sort of there is a typical image in the echo that you can see a sort of natural plication in the center of the leaflet, showing that it is prolapsing, and you can see there. In this time, this patient had had a normal, a slightly dilated root, so this sort of annuloplasty is enough. This is the sort of plication you do in the leaflet, and you can see that, of course, the result of this plication is that you will never have 100% coaptation. So, but if the other markers are fine, you should know that your repair will. And you see, this is always due to the plication you put to the leaflets. You have, but it is a central jet, is a mild jet, so you know that this patient has been repaired, I think, more than 10 years ago, and still okay. For bicuspid aortic valve, as I said, you see, this is 180 degrees. Of course, this is the joint cusp. This sinus is slightly dilated, so you can do some plication also of the sinus. You see the insufficiency typically is due to prolapse of the joint. You see here the typical fissure of the prolapse. So you see this cusp goes below. This is the joint cusp. He had a type 1 Sievers bicuspid valve with a short pseudocommissure and fusion of the right and left leaflets, and the typical jet directed towards the anterior mitral leaflet. Normally, I'm sorry, I had only static images here, but normally you should address, it's mainly plication of the joint cusp, but in the end you should take those measurements, and often it is necessary to do a minor plication also of the other cusp. And you see that typically it's even easier because you only have a coaptation line to get totally rid of any sort of residual regurgitation in the bicuspid valve. And you see also here that coaptation is above the ventricular aortic junction. This is, to see this, it was a 37-year patient that had preserved aortic root. It had a type 2 of Siever's bicuspid valve, which is in fact an unicuspid aortic valve. And in these ones you have always, but this patient was rather active, was not prone, was really pushing for not having a mechanical valve, and so this valve was repaired. But for doing this, you have to do some sort of pericardial reconstruction. So what I do in this case is I turn this in a true bicuspid valve. So I, as you see here, I use a bit of pericardium, create a new commissure, and even in this case, it's more than 70% of the tissue is still native aortic tissue. And this patient had also been operated almost 10 years ago and had not been yet reoperated, and the valve is still okay. But we know that this valve is more prone to failure, and you see no residual OR. And finally, this patient that was a Marfan patient with aortic root dilatation, with tricuspid aortic valve, and with already some complex insufficiency, not only to dilatation, but also had already some growth of the leaflets, which required, you see here, most of the insufficiency is due to this typical dilatation. Of course, here you perform this this David surgery, the reimplantation technique, but in the end, I didn't show here, you should always analyze the leaflets because sometimes these are long-lasting dilatations, and you see very nice result with just mild central insufficiency, because most of these patients, for having a nice coaptation above the annulus, require, and you should perform it, some sort of plication of the cusps. This is just to share with you our experience for the last 13 years. This is a retrospective analysis of my personal experience over those years, and most of the cases there is no formal referral in our center, but these are the patients that I had been scheduled to operate and that had aortic insufficiency, and I always tried to repair those patients over the last 15 years, but this represents the experience between 2007 and 2020, and the all comers. So you see that in the patients that had a successful sustainable repair, you have a decrease in the dimensions that are sustained over time. From these 122, we had to reoperate 12 patients, so around 10% in 20 years. And those that recur, you see that the dimensions start to increase again. But if you look at this table, from all these patients, from those 12 patients, we have quite a lot of them that had the type 3 in at least more than half of those patients, and in fact half of those patients had recurrence. Only 50% had the recurrence of aortic insufficiency. The others had progression to degeneration of the valves, and 1 patient with infective endocarditis. We compared these, we wanted to do a sort of benchmarking of our results, so we performed a meta-analysis with studies from, in a way, centers with what we consider a considerable experience, so more than 200 patient reports, and follow-up mean more than 5 and maximum more than 10 years. From this, we finally included 19 patients in this review, accounting for almost 9,000 patients, experience from 85 to 2019. So median follow-up of 6 years, maximum of 22. You see here the comparison. We used, presumably due to the thought of patients we operated less, David and Jakub, but in a way we had more patients with prolapse and used more leaflet plication. You see that the results are rather similar. We had no early deaths. We had a little less of bleeding, a little bit more of pacemaker use, but rather low numbers, and similar stroke. Cumulative survival and freedom from reoperation, similar to the meta-analysis. And this is also to show, so we also looked for meta-analysis of the use of biological and mechanical prostheses. And you see that the results of repair are at least as good, but the overall analysis showed that repair is better, but it's better presumably in comparison with the biological valves, and a bit also, but presumably non-significant with the mechanical valves. So in conclusion, I would say that aortic valve repair is a durable and effective surgery and a viable alternative to standard replacement in patients adequately selected. It is a safe procedure with a low rate of acute complication, which allows to establish a program even if in lower volume centers of this surgery. In our institution, what we have is try to have a dedicated team, so someone that looks, and for this I think that the surgeons, and we do it more and more, we should adequately discuss all the images, ideally have preoperatively a well done transesophageal echo, have the surgeon quite familiar in interpreting these results, and perioperatively also do a correct analysis of your results. We have a systematic approach to patient selection according to those algorithms that I showed you, and for my own and to assess my own results, I kept in my outpatient evaluation all the patients that I operated, so I can early on detect if there is some problem, and also to do an auto-analysis of what went best and what went wrong. And thank you for your attention.
Muito obrigado. Thanks, Adelino, for this super presentation about aortic valve repair, but it's one of the issues in cardiac surgery regarding not only the quality of the surgeon, but also regarding the integration of the cardiovascular team in this case, where patient selection plays a critical role, and then not only the follow-up. And from my perspective, one of the best issues here is your benchmarking, because it's needed to analyze the results with the aim of identification of room for improvements. Otherwise, it's difficult to identify if you do not assess the quality. Podemos fazer, ou falamos así, una especie de portuñol. Sí, Carlos.
A minha opinião é que, infelizmente, nós ainda não temos uma evidência, digamos, há estes estudos eminentemente por registro e por algum motivo, infelizmente, ainda não houve uma aceitação generalizada da comunidade científica, enquanto para a válvula para a válvula mitral é geralmente aceito. Eu não, digamos, eu pessoalmente não percebo porque é que essa recomendação deve deixar de existir. Evidente que a experiência não é semelhante em todos os centros, mas a nossa própria experiência mostra que se nós fizermos isso de uma forma sistemática e realmente é uma estratégia durável e eu acho que ninguém questiona que é benéfica para os doentes. Fundamentalmente, muitos. Inicialmente, eu fiz isto em todos os doentes, seriadamente. Temos uma população de doentes, desde jovens até mais idosos. Eu diria que nos doentes acima dos 60 anos, eu acho que é questionável. Digamos, concordaria com isso. Um doente mais idoso que vai no início, porque temos aquela vontade de ir experimentando, eu cheguei a fazer sem necessidade de reintervenção em alguns septagenários ou às vezes mesmo octogenários, em que muitas vezes o doente... Mas mesmo nesses eu não vejo muitas vezes razão para substituir a válvula. Alguns destes doentes chegam-nos com uma válvula ainda anatomicamente normal e que têm uma insuficiência pura e simplesmente porque têm um aneurisma da aorta ascendente. Qual é o racional para substituir uma válvula dessas quando com uma aplicatura subcomissural fica inteiramente durável? Se o doente tiver alterações estruturais, tiver algum tipo de calcificação, algum tipo de degeneração, eu consideraria, nesses doentes, considero claramente, revejo-me no 2B. Num doente jovem, sinceramente, mas isso são... Basicamente, o nível de evidência é C, porque é de expertos, portanto, cada um terá um bocadinho a sua opinião.
Sí, ese é o problema de moitas guidelines que están a mudar de un ano ao outro, tamén agora na de insuficiencia cardíaca, que antes non había, agora para determinados fármacos na preservada poñen 2BC, ao final, cando aparece unha letra C e que non hai evidencia cuantificable sobre eso, ou evidencia sólida, e é o que o Task Force decide. E claro, todo eso depende moito da composición do Task Force, das guidelines, claro.
Nas guidelines anteriores estavam cirurgiões com mais experiência na reparação, vão puxar para cima a recomendação. Se tiver cirurgiões que não acreditam ou tiveram maus resultados, vão puxar para baixo.
Ese é o problema das guidelines que sempre se ven cando as recomendacións acaban sendo C, que son tan críticamente dependentes dos expertos ou dos componentes do Task Force. E ao final é o que o componente do Task Force fai, e de aí a cuestión que moitas veces se fai de que cando unha recomendación é C, que se tome con moito tal, porque depende, porque agora nós aquí nos reunimos e decidimos unha cousa que non hai evidencia, ten que ser C. Podemos poñer incluso un C como tal, pero é a nosa opinión. Eu entendo que a cirurxía de reparación aórtica, porque igual non hai tantos casos como na cirurxía de reparación mitral, pois precisa unha selección cuidadosa dos doentes, pero tamén precisa un equipo técnico que sea fiable na reparación, porque aquí o problema é que a reparación ten que funcionar, porque se non funciona, pois temos un problema, hai que reoperar o doente de forma rápida ou non tan rápida, pero hai que reoperar con todas as implicacións que iso pode ter, pero eu estou convencido, acho que o desenvolvemento da reparación aórtica non é tanta porque non há tanto volumen en tantos centros con xente treinada a fazer unha reparación aórtica eficaz, non? Non sei, Darío.
Darío, gracias por esta revisión tan interesante y además también por estés ahí en este trabajo de reparar las válvulas que necesita un esfuerzo importante. Por otra parte, nosotros tenemos poca experiencia en reparar válvulas aisladas, pero una buena experiencia fue corta con el TEI. Y utilizado en pacientes mayores de 65, 70 años, la técnica sleep, correcta sleep. No sé si te parece esta técnica para pacientes que no tengan una insuficiencia aórtica.
Também, eu acho que muitas vezes é esta questão. Depois há algumas técnicas que dependem um bocadinho depois da experiência local e do resultado que nós tenhamos. Eu não tenho, digamos, não tenho usado tanto essa técnica, mas às vezes que eu usei também digamos, parece uma boa alternativa para esse grupo de pacientes.
¿Alguna pregunta más? Bueno, creo que es fundamental y determinado tipo, y sobre todo, sin a mitral, preservar a válvula mitral con reparación, ninguén dúbida, a pesar de que a evidencia tamén non é extraordinariamente sólida, porque os estudios randomizados que hai son moi limitados, pois preservar unha válvula que sea funcionalmente normal, con un tecido non moi alterado e que non teña moita tromboxenicidade e que non teña moitos problemas, sobre todo de sensibilidade á infección, porque se xa un tecido nativo, o problema eu creo que na reparación da válvula aórtica, que en un principio parecería máis simple que a reparación da mitral, pero non é así, porque a válvula aórtica non é tanto a válvula aórtica, sino que casi o complexo ventrículo aórtico, que é moito máis complexo do que pensábamos. A enfermedade aórtica acompaña habitualmente a válvula aórtica e a veces tamén a unión ventrículo aórtico xoga un papel clave, e a dificultade da reparación eficaz, eu creo que o que fai que non haya moita experiencia, e que non haber moita experiencia, pois é como un círculo vicioso. Hai pouca experiencia, se fai pouco e, por lo tanto, a evidencia e a confianza é pouca, pero obviamente se hai un equipo que garantiza resultados a longo prazo, bons resultados a longo prazo, mantendo a túa válvula, é o mismo que a posición da reparación mitral, que duda cabe que seguro que a calidade de vida, a non necesidade de anticoagulantes, a maior resistencia á infección, é dicir, os dous problemas básicos das válvulas, que a anticoagulación, trombosis e a resistencia á infección, pois deben ser superiores con válvulas nativas, e o mismo escenario que faguemos na válvula mitral.
Eu queria só chamar a atenção, por exemplo, para quem começa um programa destes, porque, por exemplo, se calhar contrariamente ao que a gente possa pensar, as válvulas mais fáceis de reparar são as bicúspides, naqueles que mais beneficiam. E se calhar o meu conselho era até começar com essas. Principalmente aquele doente com uma válvula bicúspide, simétrica, a 180 graus, tem folhetos cúspides fininhas e não tem grande dilatação. A única coisa que ele precisa é dar uns pontos, aplicar, mas normalmente a gente não tem que ter medo. Normalmente o nível de plicatura é relativamente grande. Essa é uma válvula que se repara em 10 minutos e é um resultado super ultra durável. Estamos a falar, muitas vezes os doentes destes são doentes com 20 e tal anos e que vão ter uma válvula provavelmente reparada e bem para os próximos 40 ou 50 anos.
Sí, sí.
El problema, creo, que tenemos por lo menos es el tipo de población que tenemos. No permite mucho hacer reparaciones en válvulas, especialmente la válvula, si no hay un problema de aneurisma asociado. Entonces, quizás porque tenemos poblaciones también de edad avanzada. ¿Qué número de pacientes al año crees que es interesante para poder tener cierta experiencia con buenos resultados?
Por exemplo, estes doentes, é muito simples começar a tê-los. E, como eu disse, o meu centro não tem um programa próprio de referenciação. Isto não foram doentes, tirando agora com a apresentação destes resultados, alguns cardiologistas começam a procurar especificamente para reparar estas válvulas. São válvulas que eu estava marcado para operar, para substituir a válvula, mas que eu na análise intraoperatória achei que era possível de reparar.
Sí, eu creo que é crítico a experiencia do cirurxán e a decisión do cirurxán, ainda que debe ser unha decisión conxunta. Todo o mundo entende que se tes 20 e tantos, 30 anos, cunha aorta bicúspide, con insuficiencia aórtica, Pois o máis fácil é reparar ou poñer unha nova prótesis, eso ten un problema que todo o mundo coñece a curto e a longo prazo, e está claro que a reparación aórtica en casos seleccionados é unha alternativa fantástica. O que se require é eso, ciruxaos con experiencia e que teñan resultados fiables en técnicas. Bueno, na bicúspide parece que non é moi complicado, pero en técnicas que se precisa un entrenamento. Se non hai entrenamento, hai un problema. A ciruxía de Portugal, ata agora, ten unha gran ventaxa sobre a ciruxía española, de que sodes poucos centros con miles de ciruxías, con miles. Cada ano hai centros no teu país con miles de ciruxías e iso, claro, iso dá unha perspectiva diferente. Iso foi un pouco a organización da ciruxía cardíaca en Portugal, que é un modelo que moitos países por aí están a copiar, e porque está claro que en procedementos manuais o volumen condiciona de forma crítica os resultados, e para nós é un exemplo Portugal, é dicir, San Xoao con máis de 1000 ciruxías cada ano durante anos e anos, Coimbra con máis de 1000 ciruxías, pois claro, son programas de ciruxía de excelencia que para nós, incluso pola proximidade, incluso cultural e tal, é un modelo e onde temos que en certa medida aprender e buscar vías de colaboración para incorporar esta excelencia tamén quirúrxica de algunha forma en nosa actividade habitual. Por lo tanto, moito obrigado, Adelino, por ter aceite o noso convite, de estar aquí connosco en Santiago e, sobre todo, de dar a posibilidade de traballar de forma conxunta tanto na fase de investigación como tamén nesta parte clínica. Por tanto,
Eu é que agradeço o convite, foi um gosto. Muito obrigado a todos.
moito obrigado.